Two people already waiting. एक तो હું જ છું. મોક્ષ પ્રકાશ કરીને કોઈ છે.
We are live, sir.
Okay. Rajeshwari, you can start now.
Hello.
Yes,
Hello?
Rajeshwari.
Yes, doctor.
You can start
Sorry.
now.
Yeah. So can we start?
Yes,
Please. Yeah. So good evening, everyone. I'm humbled to share that today's webinar to host from MQ Pharma. Myself, Raja Rajeshwari, product manager from MQ Pharma. It's our pleasure to be an academic partner for this webinar overall. So with this note, I would like to start the introduction. Yes.
I think
So,
the participants have not been able to get access. I'm getting phone call. Just see, check it out, Rajeshwari.
Nilima, can you check this?
Yes, ma'am.
Yeah. So to start with, I'm happy to welcome Dr. Nidhi Singh, who is the Medical Director of Tejasvi Women's and Wellness. And ma'am is a senior consultant embryologist from Panesha Hospital, Varanasi, and having more of teaching experience of almost more than 18 years with multiple national as well as international publications. And she is a member of IHERA, International Human Embryology Research and Academica. Welcome, ma'am. So second is, I would like to welcome Ms. Yoshita Tanwar, who is currently working as a clinical embryologist at Oasis Fertility Center. And she is a senior embryology and lab in charge of New Life India Fertility Clinic from Delhi. ASRM certified clinical embryologist, and she is also a member of IHERA. Welcome, Yoshita Tanwar, ma'am. Next, I would like to welcome Dr. Nancy Sharma, the Senior Consultant Embryologist from the Department of Reproductive Medicine, Jindal IVF and Sant Memorial Nursing Home. Ma'am is again an ASRM certified embryologist with the work experience of almost 9 years in the field of ART. And she has presented many research papers internationally and nationally as a presenting author. And she is also a team member of IHERA, member of prestigious national and international societies like ASRM, ESHRE, ACE, IFS, ESAR, and IHERA. So welcome you, ma'am Nancy. So over to Dr. Nidhi. Thank you all.
Good evening to all of you and happy Mahashivratri. I would like to start our webinar with a few beautiful lines written by one of our seniors, Dr. Sanket Dhumal Satya, that embryologists are like modern day Shiva. Lord Shiva oversees the endless cycle of birth and death. And similarly, embryologists witness an endless number of cells that will die early and see the day of light on a microscopic level. So a happy Shivratri to all of you, and truly believing in the nobility of our profession, I welcome you all, and let's discuss the topic that is Chronicles of Zygote today. So I would like to introduce our founder, Dr. Ved Prakash. Can I have the CV, please?
Nidhi, we can go ahead. There is no issue. No?
Okay, I'll just introduce it. Dr. Ved Prakash, sir. Sir is in South Indian Infertility and the founder of iHera. I'd like to invite Dr. Chalda Joshi, sir, who is the co-founder, sir, and Dr. Can I have the CV if possible? Just for a second.
Maybe Yoshita have that, no? Yoshita can run.
I'll just share, sir. I'll share my screen. I'm sharing my screen, sir. Give me a second. Yeah, is the screen visible? To
Yes,
all?
now it is. Yes,
So
yes.
I'd like to introduce again Dr. Chalda Joshi, sir. Sir is the lab director at
Yes.
South End Fertility and the founder, Dr. Ved Prakash, sir is the founder of our iHera and is the past president of ACE India 2022. And there is no few words to explain, sir. And now I'd like to invite Dr. Professor Sanjay Shukla, sir. Sir is a consultant clinical embryologist and an adjunct professor in clinical embryology in Mahatma Gandhi University of Medical Sciences, Jaipur. Good evening, sir. And I would like to invite Dr. Chalda Joshi, sir. He's a co-founder with having more than 20 years of experience. He's the medical director of Genes India ART Bank and lab director of RD Gardi Medical College, Ujjain. Good evening, sir. And now I invite Dr. Ved Prakash, sir, to give few words for welcoming and to introduce the first speaker of the day.
Thank you, Nidhi Singh. So, first of all, I would like to say that Happy Mahashivratri to all of you. And as Nidhi said about that words written by our fellow member Sanket Dhumal. So we are also dealing with that life and taking care of that embryo till the day 5 embryo blastocyst form. So again, today we have very good topic, zygote, and we are taking that journey from zygote and how it is formed and what is the real things we should know about the zygote. And today with that we have Ahmad Arif Mariam. He's a master in biotechnology, senior embryologist, 49 Fertility Center, Secunderabad, India. And he's completed master degree from Bharti Dasan University, 5-year plus experience in field of ART. He previously worked at Oasis Fertility and Sudha Hospital, have published abstract in ASRM 2020, perinatal outcomes of surgically retrieved in sperm in non-obstructive agiospermia. He has also participated on a collaborative research project on AI deep learning model sorry, I'm not able to see full that model for improving embryo selection and deselection using time-lapse imaging, and is a member of ACE-IFS India. His area of interest is cryobiology, early embryogenesis, and he is going to speak on all about zygote scoring. Over to Amaz.
Thank you, sir. Thank you for the elaborative introduction. Let me share my screen here. I hope it is visible, sir.
Yes, please go ahead.
Yeah. The topic that have been given today is all about zygote scoring, which I'll be presenting today. Usually, for zygote scoring, what we do is after the IVF or ICSI, we will by the end of 16 to 18 hours of insemination, we'll be checking for this pronuclei and two-polar body. That is what we are obviously doing, because we will not be having that much time to explore on the pronuclei and cytoplasmic halo and other features of fertilization of zygote. So I'll be elaborating on the grading of the pronuclei, nuclei grading, all the zygote grading actually. So then just, yeah. To begin with, infection, why zygote breeding is necessary. The incidence of multiple pregnancy has increased in the past decade in many countries, which is largely attributed by ART treatment. The multiple pregnancies is largely associated with worse obstetrics and neonatal outcomes. Since the ART rule 2020 enacted in India and not more than 3 embryos to be transferred, and other country legislation also restricts transfer of multiple embryos or growing embryos ahead of zygotic stage. Example, Germany, we can take it. And in order to minimize multiple pregnancies and to adhere the rules, elective single embryo transfer is a way to go, and that can be done without compromising on the result. Where Z scoring will be an additional key to get the most viable embryo to transfer, which may be result in clinical pregnancy. And different embryological parameters concerning every step of early development are known to have some predictive values for the implantation. Yeah, the learning objective of this study, of this webinar is about zygote grading, which is also called as Z scoring, to predict and obtain good quality blast. And the primary objective is to have a better clinical pregnancy and a healthy live birth, and to minimize multiple pregnancies. And to begin with, usually we do the zygote grading by seeing the two polar body, which is centrally located in a Judox position, and the zygote should be, the pronuclei should be equally sized, and the nucleoli, which is also called as nucleolar precursor body, which has to be 3 and less than 7 in between that, and equal sized and equal distributed and NBBs has to be present, and 2 prominent nuclei should be there centrally located, and the cytoplasmic halo to be in a moderate state. And as of now, we have the Istanbul consensus, which we will be following up. The consensus which states that if the pronuclei and the NBBs are similar, and if it is centrally located and the 2 polar bodies are good, and it is graded as Z1, and symmetrically, if it is Z2, non-symmetrically, it is Z2, and other means it has peripherally sited pronuclei. And if it is abnormal, if with the zygote with pronuclei, 0 pronuclei, just 2 polar bodies, or 1 PV is considered to be abnormal. And before going into the fertilization and the zygote scoring, let's understand the molecular events which happens in the fertilization. The first step of the fertilization happens is capacitation and acrosome reaction, sperm egg binding and fusion, and the cortical granule reaction, which is meiosis, resumption of oocyte, and activation of zygote. And to start with, the involvement of progesterone over here inside the fallopian tube, which activates the sperm, hyperactivate the sperm. And it also acts as a chemotaxis, and the glucose is necessary for capacitation. Once the capacitation is happening due to the cortical granules and the cells, due to that, the acrosome interaction takes place, and acrosome interaction with the ZP3 protein in the zona will, after that interaction, the initiation of acrosome reaction happens, and the release of pre-acrosome binding to ZP2 protein happens, and by the fusion of acrosome membrane and oocyte plasma membrane lead to the influx of calcium ion and exflux of potassium ion happens, and thereby and then the transient increase of calcium ion in the cytoplasm result in PLC.
You have to share your screen again. Ahmad, you have to share your screen again.
Okay. Okay. Is it visible, sir?
Yes, it is visible, but you have to make it full screen. Yeah. Okay. Go ahead.
Yeah. Thank you. And the next step of the molecular events of fertilization is sperm and egg binding and fusion. The fusion of sperm and oocyte takes place in the microvilli rich region in the perivitellin space, where the fertilin alpha, beta, and crescentin, which is also called as ADAM 1, 2, 3, and the integrin receptor was also present on the egg surface of sperm binding, and where the microvilli region is rich, over there the CD9 protein, which receptor is also present, which is mandatory for a sperm fusion to happen. And as soon as this interaction of lock and key mechanism happens, there the resumption of this meiosis and activation of zygote happens, and the fusion of sperm and the oocyte membrane appear to cause polymerization of actin and microvilli extension, as a result of which the sperm nucleus and other organelles are getting incorporated into the oocyte cytoplasm. As soon as this incorporation happens, second after fertilization, it undergoes a large depolymerization, massive influx of sodium ions, and repolarization via potassium leak block, which can lead to the blocking of a polyspermy and hardening of zona happens. And this is just a diagrammatic, a pictorial representation where inside the perivitellin space, where the sperm will be surfing around the microvilli region, where the microvilli will take the nucleus of the sperm inside to the cytoplasm. And this is just a diagrammatic representation where we can see A, B, C, D. The A is the sperm which is going and getting in touch with this zona, going ahead with the cumulus after having an acrosome reaction, where the acrosine is getting released and the sperm is getting into the perivitellin space on the C, and it is reaching a place where microvilli rich region and the CD9 protein, and thereby the release of this sperm nucleus getting into the cytoplasm, where the micro tubules and the cytoskeleton, that will be taking part into bringing this nucleus of oocyte and sperm into the mid position. And as soon as this happens, the influx of calcium ions, efflux of potassium happens, and thereby the hardening of zona. And for a successful fertilization, the oocyte should have the two, oocyte and sperm also contribute equally, but for the fertilization to happen, the oocyte is having an upper hand, where the oocyte maturity is mandatory, where the nuclear maturation, cytoplasmic maturation is really to look forward. As we can see the either side of the pictorial representation, where the GV BD, which is GV breakdown happens, and it enters the metaphase 1, anaphase 1, telophase 1, and the karyokinesis happens, and thereby we are getting the pure, metaphase 2 M2 oocytes. And there's just 6 steps of fertilization, where the cortical, where the sperm is entering into the entering near to the zona, and thereby lock and key mechanism of the CD9 protein and acrosine and the PLC zeta happens. As soon as it enters into the perivitellin space, the nucleus will take in, and calcium efflux happens, and thereby the hardening of zona to block polyspermy. And over here, we can see the 6 steps, what I have explained earlier. In terms of IVF, all these 6 natural conception and IVF, all this 6 step happens. But in terms of ICSI, which we are doing 4, 5, 6, it will be carried out. The first one to develop the pronuclear grading is Scott and Smith on 1998. This is a paper that they have done. They have seen the pronucleus and centrally located in the pronuclei and nucleolus and the cytoplasmic halo, which we are furthering following to grading. And over here, we can see that the pictorial representation of an oocyte, where the normal fertilization, where we can see the centrally located Xerox positioned pronuclei with less than 7 and more than 3 NPBs are present, which is equally distributed, and we can see the homogeneously distributed granularity and the moderate cytoplasmic halo and the 2 polar bodies. Here in the B picture, we can see the coarse granulation, but all the other thing is normal. And over here, we can see the unequal size of pronuclei and the very light cytoplasmic halo. And over here, we can see the less NPBs are present, whereas everything is normal. Over here, we can heterogeneously, not homogeneously distributed granules we can see, and the unequal blastomeres, unequal PNs we can see, and undistributed NPBs we can able to visualize. Over here we can see the coarse granulation and coarse high cytoplasmic halo, which results in the abnormal grading. Here the there's a paper by the Scott, which is assessing the pronuclear grading, which is grade 1, grade 2, and grade 3 and grade 4, according to the distribution and number of the NPBs present. This is a really wonderful paper. The morphology of human pronuclear embryo is positively related to blastocyst development and implantation, where they have graded in a grade 1, grade 2, and grade 3 and grade 4, where they have seen the grade according to the grading, what is the grade of embryos we will be getting on day 3 and day 5. As we can see, the trend of grade 1 grade 1 zygote is giving higher percentage of blastocyst and higher percentage of total blastocyst conversion, whereas we can see as grade is decreasing, and we can see the decline pattern over here. And the same paper have reported that even with the according to the grading, we can see the decline in the pregnancy rate and implantation. And there is another paper which supports pronuclear scoring as a predictor for embryo development and pattern of BBs in or Z score, and the presence and absence of halo had a significant effect on rate of development on day 3 and day 5, and on all over of embryo morphology score. The low Z score resulted in slow development, poor blastocyst formation, and low morphology score. And there is another paper by Pin-Yu Lin and et al. Reassessing the feasibility of zygote score for predicting embryo viability in IVF and ICSI using GnRH, ANTAC protocol, and long protocol agonist, where we can see that there is not a much difference over, formation of grade 1 and grade 2 zygote. But in terms of GnRH, this is every coins have a two phase. Over here, they are claiming that irrespective of the grading, we can get the results with either with the long protocol or the short protocol, where we can see the total conversion of day 3, which is good at Z1, and Z2 it is quite decline, and Z3 over here we can see the total blastocyst rate is quite inclined in the GnRH short protocol, whereas in long protocol the conversion is a bit low. And over here we can see the pregnancies and live birth, where we can see the increasing trend in the long protocol, whereas in GnRH protocol we can see the increasing trend. But as this paper is claiming that the study have found good quality of day 3 and blastocyst formation and cumulative embryo survival rate were correlated with Z score, but not with controlled ovulation stimulation protocol. With the GnRH ANTAC protocol, the number of Z1 is transferred in the cohort embryo was significantly correlated with the clinical pregnancies and the live birth. And there is another study which demonstrates that the pronuclear morphology is correlating with the chromosomal abnormalities and as a scoring criteria for the embryo. That was done by Luca et al. And we can see over here they have graded based on the positioning of PN, positioning and sizes of NPBs, and the position of polar bodies. And as a result of which they have told the position of pronuclei within the ooplasm, the size and distribution of nucleoli, and the orientation of polar bodies with respect to pronuclei were highly predictive for the absence of complex chromosomal abnormalities in developing embryos. And zygote with jutoxed pronuclei, large size nuclei, and the polar bodies with small angle subtended by pronuclei and pronuclear were configured associated with high rates of euploidy. And conclusion of that is the combination of the pattern related to the pronuclei zygote morphology indicated 4 configuration where the proportion of chromosomal normal embryos was significantly higher compared with other configurations, suggesting the validity of scoring of generated by PGT patients. And the take-home message of this 2PN breeding is in the era of elective single embryo transfer, the addition of other advanced morphological breeding to predict the most viable embryo to transfer for clinical and healthy live birth, that is artificial intelligence and central neural network grading of embryo in static image and live imaging, time lapse with own central algorithm, NICS and PGT. The zygote grading will be an additional tool to achieve the desired result. Thank you.
Thank you, Mr. Ahmad Ali. Ved sir, are you there?
Yes, yes, I'm coming. Thank you, Amaj. Thank you so much for that excellent presentation. And it was very good actually. And you told us about all the process of fertilization, how it is happening, and all the incidents. And I think you explain all the things about NPBs also. But there is one question from me. You know,
Yes, sir.
two PN is there, but they are not close to each other. They are separated. What do you say about that? They are not too close. Not
They are-
about NPBs. I'm speaking about the PN, whole pronuclei.
Yeah.
How do you score that?
Score that as long as like as per the earlier slide which we have demonstrated, where they have seen the position of the pronuclei, whether it is a distanced or the close to each other in a digitox position, where they have graded. The grading as per what we do is if I mean on the between the 16th and 18th hour of the post insemination, it has to be centrally located. And as long as it is centrally located and close to nearby, we can assume it as grade 1 and if equal sized, irrespective of the nucleoli.
Okay. There is one question that causes for single PN and 3 PN.
Possibility of a single PN could be the result of not getting insemin. I mean, in a ICSI, mostly in ICSI it happens where oocyte is getting activated due to the rupture of this cytoplasm, whereas the sperm must have not entered into the cytoplasm and the single PN would have arisen, and that is considered to be an abnormal one. Whereas in 3 PN, as we can see in Istanbul consensus, where they have demonstrated where the 3 PNs, all the multi-nucleation is considered to be an abnormal, where there it could be a factor from the sperm or it could be a factor from the oocyte, where it will be carrying 3N or 2N chromosomes.
And what do you say about single PN after 2-3 hours that 2 PN is occur?
That is still controversial actually. Like during the time of the fertilization check, it has to be 2 PNs. If it is not, then it is considered to be abnormal. That has to be culture separate, and NICS or PGTP has to be done. If it is euploid, then we can go and transfer it.
And there is one more question. What is the exact time for zygote scoring?
Exact timing of zygote scoring is 17 to 18. I mean, in middle of that, as per as per Istanbul consensus.
So you are talking about after ICSI or you're talking about IVF? After IVF.
I am talking about after ICSI.
Okay. And what about the IVF?
16 hours most probably.
Sorry, I couldn't hear you. Please.
I'm not able to hear you, sir.
Sorry.
You are not audible.
What about IVF? Zygote scoring after IVF.
I'm sorry, sir, you're not audible.
Mr. Amaz, am I audible?
Yeah, you are audible.
Sir is asking in cases of ICSI, you have told 16 hours, but what about in cases of IVF? What is the exact time where you recommend that we should see for the PN check?
His network is not there.
I think so. He has logged out, sir. There's some problem.
There is some problem.
We can go with the next speaker, sir.
Next speaker, yeah, please.
So I would like to call Dr. Charles Joshi to please introduce the next speaker. So, sir, you can take over, please.
Please.
I'll share the screen, sir.
Yeah, please. So we learn about how to do the zygote scoring. Now there is another topic, and the speaker for that, Nivita Gugnani. She has done masters in reproductive biology and clinical embryology from one of the premium institute of the country, All India Institute of Medical Sciences, Delhi. She is currently working as an embryologist in Milan, Delhi. There is so many list of the publication in her name, and like an expert commentary on essential equipment, supplies, and culture media, optimizing embryological aspects of oocyte retrieval, oocyte denudation, and embryo transfer, comprehensive analysis of global research on human varicocele, and taking a closer look at the key performance indicator in ART. And she's co-authored a chapter on omics in ART, and she has her abstract is accepted for Fertility Conference 2023. Over to Nivita. Nivita, are you there?
Yes, sir.
Yeah, please share your screen.
Good evening, everyone. Is my screen visible?
Yes,
Yes, it is.
Yes, please.
Okay. So I will be discussing about the relationship between pronuclear morphology on embryonic development, the current status. So before I start, just a brief introduction. So fertilization, as we know it, underpins the extremely delicate transition from the meiotic status of the gametes to mitotic dynamics of the early embryo. And the developmental and genetic studies, they have revealed really unexpected complexities and critical points of meiosis-mitosis transition. And this knowledge has basically increased our awareness of the importance of fertilization as a cellular platform shaping the pre-implantation embryos. So now there are certain fertilization biomarkers of embryo developmental competence. I will be discussing all of them briefly, but majorly I would be talking about the pronuclear morphology, which is my topic of discussion today. So I would be moving in no particular order, but my major focus would be on the pronuclear morphology. So starting with the second polar body emission. Now the timing of the second polar body emission as a potential biomarker of embryo quality, it has been overlooked for decades now. But the recent studies, they say that there is not much correlation between the time of the polar body emission and the euploid status of the blastocyst. And this is very well supported by this study, which says neither the time nor the type of the polar body, as in whether the polar body is fragmented or irregular in shape or however it is, it doesn't affect the ploidy status of the embryo. So yeah, as I mentioned earlier, it shows that the polar body angle size and the polar body status, they're not related to whether the blastocysts are euploid, aneuploid, or mosaic. And in the process of embryo selection, the embryologist should never really, predict the euploidy of the blastocyst based on the state of the polar body. Now, moving on to the pronuclei. Now, there is an increasing evidence from the time lapse which suggests that the time of appearance of the pronuclei and their juxtaposition, they are associated with the embryo quality and subsequent pregnancy outcomes. So I will be discussing certain divisions under this. So first, I will be talking about the time of the pronuclear observation. Now we know that the male and female pronuclei, they appear synchronously at about 6 hours after ICSI. And this pronuclear juxtaposition, it usually occurs at a mean of around 8.5 hours post ICSI. And this repositioning and the centrally location, it occurs 24.5 hours after ICSI. So now this study, this says that they basically took 78,348 embryos, and they found that between 15 to 17.5 hours, they chose this bracket. And they found that 98.19% embryos, they had the highest proportion of oocytes with visible pronuclei at 16.6.5 hours post-insemination. And as the time increased, the visible pronuclei, it decreased. So the idea is to basically fine-tune the time at which the fertilization assessment takes place, because this basically will increase the assessment and it will help us maximize the number of fertilized oocytes that can be identified, hence increasing the number of usable embryos. Moving further, we will talk about the off-center PN position. Now, once juxtaposed, the position of the PN is basically, it determines the orientation of our first cleavage plane. So a stable off-center position has been associated with abnormal cleavage. and a decrease in the odds of live birth rate. So there was this study conducted by Barbaret in 2019, which said that the analysis of the live birth rate according to the PN position and features of the cytoplasmic halo, which I'll be discussing later, was highest when the PN position was central. When the juxtaposition was central, at that time, the live birth rate was the highest. So this is just a diagram which basically gives me description of the morphokinetic events and the morphological morphometric parameters. Kindly excuse me just a second. I'm sorry for the interruption. Moving on. Yeah. So now the next thing that we are going to talk about is the mutual orientation of the polar and the PN axis. So the position of my polar body to extrusion, it determines my oocyte polar axis. And the failure of the polar and the pronuclear longitudinal axis to basically align, now there is a chance that it might increase the rate of developmental arrest or abnormal cleavage. So there is this study which was conducted in 2018. Now this says that the angle between when the angle of the polar body to extrusion was less than 45 degrees from polar body 1, the clinical pregnancy rate was higher as compared to when the polar body 2 was extruded at an angle of more than 45 degrees. Now this was done in 2018, but there was a contradiction to this study, which was conducted in 2021, I guess. Now this study very clearly said that there was no difference in the relationship between the polar body angle and the embryo euploidy. So the current status is not very clear, but this recent study says that there was no significant difference in the angular size distribution of the two polar bodies with the different ploidy status. So now this this picture basically talks about the pronuclear juxtaposition and breakdown. So here we can see the first part of the picture. It shows a fertilized oocyte which exhibits a pronuclear juxtaposition. It is centrally located, and the synchronous breakdown of the PN. Second image, the B part, it shows us a fertilized oocyte which wherein the pronucleus, they are non-juxtaposed, but the pronucleus, they are synchronously breaking down. The third one shows wherein the pronuclei, they are juxtaposed, but the breakdown is asynchronous. And the third one shows both of them are in asynchrony, as in there is non-juxtaposition and there is asynchronous polar PN breakdown. So this is just image which the time-lapse image, which basically shows us the same. The first one is showing us the off-center pronuclei, and the rightmost image is before the breakdown. So last one is the non-juxtaposed one. The middle one is basically there is no apparent abnormality before asynchronous PN-BD derived from initial isolated disappearance of the PN positioned. Now, there was this study conducted in 2021, I guess. Now, in this, they observed 27 fertilized oocytes. Now, this was done, 27 fertilized oocytes with non-juxtaposed PNs. It was observed that there was a reduction in the rate of blastocyst cryopreservation. And there was another study, which my fellow colleague just mentioned, in 2003 that was conducted, that when the PNs, they are not juxtaposed and they're not centrally aligned, there is a significant change in the blastocyst rate. So this basically suggests that non-juxtaposition may be compatible with the post-implantation development if growth with the blastocyst. So basically, if the blastocyst is formed, The post-implantation impact, it can be positive also. The implantation, the positive implantation, matlab the embryo can implant. But what is important is if it is going till blastocyst, that is the idea here. If the centrally positioned pronuclei, they are juxtaposed, and if they are going towards the blastocyst, that is where our main observation period should lie, basically. Moving on to the PN size. So we all know that the male PN size is usually larger than the female counterpart, although this difference usually declines before the pronuclear breakdown. So there were two studies by the same group. One was conducted in 2017 and the other was conducted in 2018. The first study, it said that the difference in size between the male and the female pronuclei immediately before the breakdown of the pronuclei is very small among patients with a successful birth, and the large difference in size between the male and female pronuclei, it could be related to the chromosomal abnormalities. And second study also reported the same thing, that the difference in size of the male and female pronuclei in zygotes of patients who gave birth successfully gradually decreased, although difference in the size of the male and female pronuclei in patients who did not achieve live birth, it did not decrease. So now this is the example of zygote, wherein the male and female pronuclei were successfully tracked. In the first part, we can see a fertilization cone is frequently observed. In the B part, we can see the male pronuclei is formed within the fertilization cone here, and it has moved towards the center of the oocyte. And from C to D, the female pronuclei has formed close to the second polar body, and it is being drawn to the male pronuclei. Now, this is basically a time-lapse image of the zygotes which produced successful live birth rate and which did not produce successful live birth rate. So in D part, we can see the zygote which produced a successful live birth rate, and the C part we can see the zygotes which did not result in a successful live birth rate. Now herein we can see the third image of both these, B and C. We can see the difference in the pronuclei. In the C part, we can see it very clearly that there is a difference in the size of the two pronucleus, while in case of the B part, there isn't a significant difference in the size of the pronucleus. Moving on to the NPBs. Now there is limited evidence here. So first, what are NPBs? So these are basically aggregation of dense fibrillar material of basically unknown composition, and they are visible in the PN of the fertilized egg. So basically the patterning of these particles is associated with the chromosomal arrangement during fertilization. And it was in 1999 that a study was conducted which said that the embryo's ability to cleave an implant was related to the two alternative NPB patterns. But certain recent studies, they don't show much of a significant correlation between the developmental potential and the NPBs, much of a significant correlation. So this is one study. Now herein it shows that the distribution of the NPB patterns, the quantity of polarization, now this was in 2012. This did not differ between the live birth rate and no live birth rate group, and the average score, it increased over time, but there was no difference in the live birth rate and the non-live birth rate zygotes. Now, there is this recent study also. Now, this says that clustering defects do lead to aneuploidy and micronuclei impairing the embryo development. So now what happens is, this is what the actual picture looks like. So when the two PNs, they come close together, this is what happens. When they come in contact with each other, there is chromosome clustering, then there is breakdown. So basically, there is spindle assembly. They are aligned uniformly on the metaphyseal plate, we can say, and then the two-cell embryo, it is formed. But what actually happens is during the migration of the intact pronuclei, the parental genome, we know, they polarize towards each other in a process that is driven by centrosome, dynein, and microtubules. Now, what happens is the maternal and paternal chromosomes, eventually they cluster at the pronuclear interface in direct proximity to each other. Now, here we can see in the first case, the two PNs, they are juxtaposed. In this case, the NPBs, they are closely aligned. So the parental genome cluster, it basically ensures the rapid unification of the parental genome on nuclear envelope. Clustering, it often fails, and this might lead to chromosomal segregation errors and micronuclei which are incompatible with the embryo development, which is clearly visible in the last picture, wherein there is unclustered, they are not properly aligned, and in the end we get micronuclei, and as I mentioned earlier, that these micronuclei might lead to aneuploidies. These clustering defects might lead to aneuploidies. So, but there is, and so apart from this, there is another thing that has come to people's notice, and that is the migration speed of the NPVs. Now, the people are now researching, and they have found this to be an attractive biomarker for non-invasive embryo selection. Now, this study basically demonstrates that in zygotes, which have the potential to develop into a blastocyst, and therefore with the potential to lead to live birth rate, therein the migration speed of these NPBs is faster than in the zygotes that are arrested prior to the blastocyst development. So this is being observed as an attractive marker for non-invasive embryo selection. And this is a recent study only. It was published in 2021. Moving on to the cytoplasmic movements. Now, cytoplasmic flares. Now, what are cytoplasmic flares? These are basically glassy appearances which radiate from the site of the formation of the male pronucleus. Now, it was detected, this Neo et al., they detected the same phenomena in almost all normally fertilized oocyte inseminated by HC or IVF. Now, the absence of flare was associated with no or abnormal fertilization. In addition, the timing of cytoplasmic flare precisely predicts the time of appearance of the male pronucleus. These were the studies in 1997 and 2008, but still this topic is debatable, and there is no conclusive result on whether the cytoplasmic movement is a good predictor of embryo developmental competence or not. Moving on to the cytoplasmic halo. Now, formation of this halo, we know it basically starts 11 hours post insemination. Now, first of all, what is a cytoplasmic halo? So, in most of these fertilized eggs, the assessment of the pronuclear formation around 16 to 18 hours post insemination, it reveals a cortical area of reduced cytoplasmic granularity, and this area of reduced cytoplasmic granularity is what we call as cytoplasmic halo. Now, this is not usually observed, it's not observed in non-inseminated or non-fertilized eggs. So it reflects the displacement of organelles, mainly mitochondria, from the cell periphery to the center in order to support the pronuclear function. So it was observed that its disappearance closely precedes the PN breakdown by less than 1.5 hours, and it involves the radial distribution of cytoplasmic material towards the cortex. So in a recent large and well-designed study, it was found that a convincing evidence was found which showed the importance of the cytoplasmic halo. They reported higher rates of abnormal cleavage in halo-negative zygotes, and it was the first time that they described that the absence of halo was actually significant biomarker for the embryo quality. It was found that the halo presence was positively associated with embryo development to the blastocyst stage, and the distribution pattern of this halo, it did not affect either the embryo pregnancy outcome. So what it affected was the developmental competence. So yeah, this diagram is basically briefly giving an idea of what I said earlier. The developmental significance of cytoplasmic halo occurring at fertilization, of course, it has been controversial. This has the cytoplasmic halo is thought to be a marker of microtubule organized translocation of mitochondria and other cytoplasmic components, as I mentioned earlier. Yeah, so to conclude, the conclusion that we all expect, a good embryo leading to positive pregnancy. So that's how I would like to conclude. So we know that like a single static observation is unable to capture the extreme dynamism of fertilization and its numerous subprocesses. The introduction of this time lapse has actually made our lives easier. It has actually helped us to not select the embryos, but to basically deselect the embryos, taking into consideration these minute things which were at some point overlooked. So that's all about it. Thank you very much.
Thank you, Nimita. Thank you so much for excellent talk. You very well explained everything. There is one question from our friend Nishad. Can zygote scoring be the only marker for implantation? If not time lapse, then what parameter in Z scoring should be taken into consideration as a biomarker for blast formation and implantation?
So just a second. Can zygote scoring be the only marker for implantation? If not time lapse, then what parameter in Z scoring should be taken into consideration as a biomarker?
For blast formation and implantation.
No, zygote scoring cannot be the only marker for implantation, of course not, because before time lapse right now, they are also still scoring the, just by looking at the morphology on day 3 or day 5, they're still scoring the embryos and yeah, they are transferring embryos and there are positive pregnancy positive people are getting positive pregnancy. So no, zygote scoring is not the only marker for implantation, I would say. This is with time lapse that we are able to score the zygote. This is with time lapse that we are able to check for if they are centrally located, if the NTVs are migrating, if they are properly aligned and all of this. So no.
So what do you say about if there is no time lapse, what to do on the basis of zygote?
So if there is no time lapse, then in cases where there are where PGS is recommended for patients who have a history or something, so that is there.
You know that there is some places there is no that facility of PGS and there is in small area. So what to do? Because there is only they will rely on the 2 p.m. scoring. How to go about that?
So in that case,
and one more thing, is it necessary to check 2 p.m.? What do you think about that? Because there are some centers and they are not doing 2 p.m. scoring as well. So what to do about that?
Sir, I would say yes, it is necessary to check 2 p.m. because we might miss a 1 p.m., we might miss a 3 p.m. So it is important. And I don't think it would be a task to calculate the time of insemination and accordingly check the PN. So that would only take you to just calculate that. Yeah, of course, there would be times when you, even if you calculate the time and you check the PN at the exact same time, you won't be able to check. So that is there. But I don't think it would take much of an effort to actually calculate the time and go check PN at the exact same time where the indicated time basically post insemination. So
you know that what they say, if you are doing ICSI, so there is no chance of doing there is no need to do 2 p.m. to check the 2 p.m.
So what if there is some female factor? Okay, so we transferred one sperm. What if there's some female factor because of which a 3 p.m. comes? So I don't think that is something that we can avoid or something that we should even consider avoiding.
So I think the conclusion is like that you should check 2 p.m. It is important to check 2 p.m. and to see that how that embryo will grow, and you can deselect the embryo on the basis of that thing. Thank you so much, Nivita. Thank you so much.
Thank you, sir.
Over to
Thank you.
Nidhi.
I'll just share my screen. So just a minute. So now coming to our panel discussion, I have 2 words to describe our moderators. That is wonderful and dynamic. So the first moderator of the evening is, just to give me a second. Is it visible?
Yes, it is.
Yeah, so Dr. Krishna, sir, he is a scientific director at OSC Center for Reproductive Medicine in Hyderabad. Sir is a Master of Clinical Embryology from Monash University in 2008 and is a postgraduate diploma in reproductive sciences from Monash in 2007. Sir, at OSS, his main areas of work is cryobiology, in vitro maturation of oocyte, andrology, and men's health. Currently, he is working on employing newer techniques to improve the success rates of in vitro fertilization in PCOD and recurrent IVF failure cases. Good evening and welcome, sir. I would like to invite the next moderator, that is Dr. Nishad Chumote. He has done his MSc Biochemical in MSc Clinical Embryology from University of Leeds, UK. He is currently the lab director of Icon Hospital, Nagpur, lab director at Nucleus IVF, Nagpur. Good evening and welcome, sir.
Right, thank you.
So I would like to invite the moderators to please introduce our panelists, esteemed panelists.
Right. So let me share the screen here. Okay. Right. Okay. Fine. So our panel is star-studded today. We are having obviously none other than Dr. Charudas Doshi with us. Obviously, sir does not require any introduction. And yes, it's wonderful to have you, sir. I hope, sir, you're here.
Yes,
Yeah,
yes,
but
I'm here.
Lovely to hear your voice, sir. Wonderful. Yeah. Can we have the next panelist here? Yeah, so our next panelist again is Dr. Rajiv Sharma. He's done his PhD in zoology and master's in embryology, and worked as general manager embryology in Morpheus, worked as adjunct faculty at Aligarh AMU, worked as embryologist at MTBC Agra, and lots of the centers, has set up more than 40 IVF labs, trained so many embryologists on ICSI and vitrification, and authored and co-authored of international and national research papers and books. We welcome you, Dr. Rajiv. May I have the next speaker, please? Hello, sir. Wonderful to hear your voice. Right. Wonderful friend of mine. We have Rahul Sen with us, star-studded CV already. He is the managing company member of ACE, as well as nominated as mentor for HM mentorship. Treasurer Isha Rajasthan, in the field of embryology since 13 years, has lots of publications and reviewer of journals of JHRM, member of ISAR IFS H-Ray, recipient of IFS Achievers Award, and definitely it was a wonderful event this time. And his field of interest is micromanipulation, embryo culture, system, and cryopreservation. Maybe have the next panelist.
Thank you, Nisha. Thank you.
Hi.
Thank you, dear.
Wonderful to hear you. So next next panelist is Dr. Paresh Makwana, another wonderful friend of mine. It's wonderful to see so many friends of mine and such a nice CV. Everybody's having, they've done so many nice things. So Paresh again he's the head in Wings Hospital, a member of IFS Gujarat chapter, also lifetime member of Fertility Preservation Society, a member of ASRM H-Ray, served as freelance embryologist in India and West Africa. Trained national, international embryologists, done more than 6,000 embryo biopsies, publications and articles, and invited as faculty in national and international conferences. So yes, wonderful. It's wonderful to see you here, Dr. Harsha. More than 21 years of experience, lots and lots of training done here, lots of experience. Applied for patent in male infertility. She's doing a wonderful job in this research, as well as experience of more than 3,000 embryo biopsies for PGT. Yes, we have a PGT guru here. Published chapters and papers in national and international journals, guided UG and PG students. So she's been a wonderful trainer and a teacher, as well as a mentor. Participated in clinical trials related to ART techniques. And I believe she published a wonderful paper recently and delivered many lectures in national and international conferences and workshops. So Harsha Ben, welcome you. Then we have Falguni Patro. Wonderful to hear from you. We have Falguni Patro with us also. He's done his master's in biotechnology, as well as active member of ACE and embryology, and research interest is PGT and vitrification. So hi Falguni, wonderful to hear from you and see you.
Yeah.
Right, so allow me to share the screen now. And Right. I believe you can see this.
Yes, sir. It's visible.
Lovely. Yeah. So you can see the full screen now. Slide preview.
Yes.
Yeah. So yeah, it's wonderful to, yeah. Most importantly, hi Krishna. It's wonderful to hear from you and see you.
Nice
So
to-
yes, so we both are looking for a wonderful panel here. And Krishna, it's all yours from here. Please take it away.
So I think, it's nice that, Ahira is wanting to look more at the zygote and the basics of fertilization. And we've got a really, really experienced panel with us today. So I think let's quickly get into and get more inputs and insights. What
Sorry,
is
Krishna,
that we don't really like?
Krishna, Dr. Sanjay Shukla is here. He is also on panel. Okay?
Oh, lovely.
There would nothing be more happier to have Dr. Sanjay Shukla with us, the senior most embryologist in the country. Dr. Sanjay, really looking forward to get more inputs and learn from your vast experience. Welcome on board.
I welcome you, sir. It's wonderful to have you with us.
Thank you. I would like to, I would try to see if I could help.
That'll be nice, sir. Thank you so much. So I think, none of us want to see failure in the first step. I'm sure we all put in lots of effort in coming up with the best lab, trying to have the best SOPs, QCs. We want to do our best with ICSI, but every morning, doesn't matter whether we are 1 year old in the lab or 15-year-old, not seeing it 2 p.m. The right way really cringes our heart. And today here we are to discuss, what are the reasons and how could we avoid, and have we really reached a point with all the technology and science that's developed to a point where we can avoid total failed fertilization is what the discussion is about. So let's first quickly get inputs. Is presence of 2 p.m. the only indicator of fertilization? To my expert panel there. Dr. Harsha or Paresh, one of you could take that question. Is that the only way we would get to know that the oocyte is fertilized?
Hello, everyone. Yeah, presence of 2p, and obviously we can say the oocyte is fertilized, but sometimes we lose the timing of 2p and seeing. So two polar body also indicate the fertilization is done there.
Great. So, Dr. Sanjay, with your experience, sometimes there's two polar bodies. Would it be a fragmented polar body and not indicate fertilization? Or
Yes, it
the two
would be.
polar bodies is always evident?
No. So it's a little bit a misleading thing. Even the presence or absence of halo may not always be a true indicator of fertilization. So,
Okay.
with
Wonderful. So we would be a
time
little
lapse.
particular to see the polar, the two PNs there. Along with that, probably a halo and a two polar body could be reassuring. All right. So, Doctor, the next question is probably to Dr. Rajiv Sharma. Dr. Rajiv, there are times where you see a 2-cell or a 4-cell when you've come at 16th hour in the lab in the oocyte. Does that make us feel happy that the embryo is all really quick and wants to go and create a pregnancy? Or are we concerned looking at a 2-cell?
On 16 hour to 18 hour, if 2-cell is seen, if something is concerned, but if early cleavage is seen around 24 hours, after 24 hours.
So premature appearance of a 2-cell would concern us. That probably wouldn't be the right thing.
Yes.
And it probably is a point to deselect the embryo.
Yes.
Wonderful. Thank you so much. So I think, yes, polar body and halos and everything could indicate fertilization, but I think we're looking at the pronucleus as an important factor.
Nishad, let's go to the next slide. So, Nishad, you can take over this.
Yeah. So yes, I think we had a good discussion even before the panel regarding the zygote scoring, about the zygote quality, whether time lapse is important, whether just morphological grading of zygote is important. But how important is the oocyte quality when it comes to the fertilizing failure? Is it really important that you should actually take pictures or score the oocyte also, and not only start with zygote scoring? Yes, I would like to start this with Dr. Harsha.
Yeah, definitely. Oocyte quality also affect the fertilization. So we should inform our clinician. We should take abnormal oocytes picture at the time of ICSI, and we should follow up the whole cycle with the oocyte quality. I think so.
Right. And what is your take on the oocyte, since we are talking about fertilization failure? So what are the factors that are responsible, and how can we take care of these factors? How to preemptively avoid it and then retrospectively avoid it? Can you tell me a few factors that really make a difference when it comes to fertilization failure with respect to the oocyte quality?
It may be age factor, poor ovarian reserve. I think so. Sometimes oocyte activation failure also at time of ICSI technical error, or maybe genetic reason also. We can say few mutations in male and female are affect the oocyte activation, like PLCZ1 in male, ALC9, which is also affect the fertilization. WEF2 is also affect oocyte maturation and oocyte quality. So these are the few mutations which can affect the fertilization failure in oocyte and the sperms.
All right. Charudat sir, could you like to add to it? What are the other factors in the morphology of the oocyte that can affect the fertilization result?
Yes, I was just thinking about that only, that anything abnormal, if you see anything abnormal, means what I feel is that we cannot predict really whether the fertilization is going to happen or not, because in my experience, I've seen where the very poor quality oocytes, very dark granular cytoplasm oocytes also yielded good embryo later on. But the thing is, here the important part is next day, still after so many years, this question is there. Always a dilemma is there whether tomorrow fertilization will happen or not. So as far as my opinion is concerned, I would like to see and report any abnormality if I have seen. Maybe it is cytoplasmic or zona thinness or abnormal polar body or anything, or smooth endoplasmic reticulum presence. This has to be reported. And definitely, yes, we should discuss with the clinician that this is the quality of oocyte which is recovered, and probably I may expect some abnormalities or some abnormal fertilization in this. So this will make it's more convenient for us to expect what we are expecting, and then if suppose fertilization, poor fertilization is there, we know the reason behind it.
Right. Sanjay sir, I would like to just ask you one more question regarding this, is whether the cytoplasm and what are the cytoplasmic parameters that actually determine and lead to fertilization failure. If you can tell us in brief about them.
Well, looking at the oocyte, you cannot pinpointly say that this particular oocyte has some cytoplasmic defects. There are certain indications like the presence of ACR discs in the clusters. But still, we do find the normal fertilization with ACR discs. Maybe they are not competent enough to produce healthy live babies, but they do fertilize. So looking at the oocyte morphology, you just can't predict that this cytoplasm is not good to lead to fertilization failure.
Right. And if
Just
we also
to
talk
ask
about
that, to any of the panelists out there, is there a way we can say that the oocyte is all ready for fertilization to accept the sperm? Are there any such indicators? A curious question.
Except the nuclear maturity.
Unfortunately, we do not have So presence of the first
During the
only
screening, sometimes depending on the appearance of the cumulus. So for that time also we can think, yes, the cytoplasmic will be little bit mature, and also that we can predict, because we have found in a lot of cases where the cumulus is not properly expanded, and you have did the ICSI little bit early or sometimes. So around that time your failure used to be there. So if you are thinking your cumulus is good, then you can plan your ICSI as per your time. But if you're thinking your cumulus is a little bit less expanded, then you can wait for some more time for the cytoplasmic maturity. Because nowadays the very common factor is that when we are doing ICSI with around 30 to 40% of egg, we are not getting that that the cone shape types of thing. We used to get a straight line. So they are the some type of indicator, yeah, the egg might be fertilized or it may be dead, because the cytoplasm has to degenerate the chromosomal cap of the sperms, and the DNA will come out. So the cytoplasm should be mature. So that also one point.
Lovely.
Wonderful. Right. So yeah, as you mentioned, Falguni, that is right, that the cone formation in the cytoplasm, if it is absolutely powdery and there is no actual cone formation, the highest chance of fertilization failure can happen. So you have to report this so that you are one with your clinician, and you can report, like you are already ready with the reaction and you don't bear the brunt of the situation. So yeah, these are the factors that you consider. Another one factor I'd like to add is the SER, as sir has mentioned. If it is more than 15 micron, then you'll have a problem again, because it can break, or else fight. And also it is mentioned that it will also result in failure of the fertilization. So these are the factors you can consider while you're doing the ICSI. So itself, it's a good method of determining whether the oocyte quality and these factors can result in a good fertilization or not. Yeah, Krishna, I can take the next question, please.
Yeah. So I think we just spoke about the abnormalities in the cytoplasm and sometimes the nuclear test, and we had an idea of this. But are there any specific morphological deformities where you could just predict and say, what, I'm up for a very poor fertilization tomorrow? Are we really come to that point either through a scoring system, or I don't know if there's an AI thing? Can an embryologist, forecast a poor fertilization or failed fertilization? And then how do we do that? If there's anybody who would want to throw some light on it.
Yes, can I jump in?
Yes,
yeah, Rahul, please go ahead.
Yes. Yes, as very well mentioned by everyone in the previous question, that there is the importance of oocyte quality and how it actually can predict with the fertilization and with the embryo formation. Yes, but the thing is, as Dr. Krishna has already mentioned, the oocytes which we retrieve, they are not of not all are of the same quality and sizes, but there are the different quality of oocytes which can be abnormal, as it's already mentioned in the picture. The major of the oocytes with the size, that is the giant oocyte with the large size polar body and the abnormal appearances in cytoplasm, they can be considered as an abnormal oocyte to perform fertilization. So my basically
and how crucial it is to look at the spindle, or imagine and consider the spindle's position. Would that really lead to a failed fertilization?
Basically, the technology of spindle viewing, it basically relocates an operator where to inject the sperm. So I'm not basically a pro user of spindle, meiotic spindle, but the thing is, it basically helps an operator to just to relocate the size, the place where to do the injection. So
so Charu sir and Sanjay sir, nowadays we're talking about technology and high funder thing these days, but I'm sure in the era where you people did ICSIs, I'm sure there wasn't any way you could have looked at the spindle. But do you really think the chance of damaging the spindle to an extent where we have a total fold failure. Is this something that we should be worried about?
No, I don't think it is. If we just from years together now, we are fixing that position of polar body at 6 or 12 o'clock and considering this. And most of us are, means that nowadays the machines and everything is so advanced, the alignment and everything is so particular that chances of getting spindle damage is comparatively much lesser. But yes, one cannot say that it's 100% not there. But still, I feel that it's not that very important till you are positioning it properly and doing it a proper angle. Because many times, even if spindle is at 6 o'clock or 12 o'clock position, polar body you fix, but the angle of injection is not proper, still there is a possibility of damaging anything present in cytoplasm, not just the spindle.
Lovely.
So there may be failed cleavage in such condition when even if you see fertilization, but you may not see the cleavage ahead. So,
all right, wonderful. So I think so far what we've looked at, oocyte half the story, and it's the nuclear maturity which probably is indicating the oocyte is ready to accept the sperm. And second, there are certain morphological dysmorphisms which could probably predispose lower fertilization, but nothing absolute at this point in time. Viewing the spindle with the foldscope is not an absolute.
Just I want to add,
yes,
Dr. Krishna.
Sanjay.
We are doing a study with my team around 2000 somewhere. The eggs we have find out those eggs are having low pre-vitelline space, means they don't have a pre-vitelline space. It's or it is completely it's not there completely in the egg. So those eggs we have found with a low fertilization rate.
Wonderful. That was a very, very good insight. Thank you so much. So
if I may ask an additional question to that, when you mentioned that the perivitelline space is low, what can you tell the actual diameter of that area? Like how low do you think it is?
Not of the diameter. We are considering those eggs where totally there is no pre-vitelline space. If you'll see having a thick zona, and so those types of eggs we haven't measured, but yeah, we can make a prediction. Yeah, it's okay, and it's not there, or it's a very large pre-vitelline space. Not of the diameter we have mentioned.
The issue is that if there is a polar body, there is bound to be some perivitelline space. If there is no polar body, it will be completely tight. So how do you define that?
Just near to the polar body, you will found a pre-vitelline space, but from the other part of the egg, you will see it is completely stick with the cytoplasm.
Okay. Most of the time, I think the fragile eggs, what we see, very delicate kind of egg, they don't have that much of perivitelline space otherwise.
Yeah.
Wonderful. So let's move on to the next slide and put
Krishna,
more.
can I have
yes,
comment?
Yes, Sanjay sir, please.
So I have two comments. One regarding the time lapse, not time lapse, but the pulse scope. So Daniel Henka from the Czech Republic has done a beautiful work showing that even after having a polar body extrusion, if you see through the pulse scope, you may find that the spindle is in, or the oocyte is not in a true metaphase 2 state, but it is in the anaphase of the metaphase 1. So at that time, if you inject, and it triggers certain cascade of events, so that thing may lead not to proper stimulation of egg, and then it may arrest fertilization. So that is one thing. And another thing is that, I mean, according to his experiments, its further waiting is rather helpful. Another thing is regarding the perivitelline space. Again, expert from UAE, Yusuf, who is our regular expert in iHera webinars, he is working on this particular aspect. I'm not remembering what size he gave, but he is in this and he is measuring all those dimensions.
So I think we're yet to find some evidence to see if there's a particular oocyte dysmorphism that could lead to a total FERL failure. Right now, I think we do not have the exact answer if there is a reason for a FERL failure.
Yeah, even I believe with the mitotic spindle, if it is more than 90 degrees, I believe it is Laura G's paper of 2013. They have also mentioned if it is more than 90 degrees, then there will be a higher chances of fertilization failure. So that is something which needs to be, the sampling size is not enough. So I think more research is required, but definitely there is some scope. But practical approach, I believe my panelists all will agree that we don't need a pole scope. As of now, we are good without it.
Absolutely.
Yeah.
See, poloscope,
Yeah, please go ahead.
Poloscope is a tool for frozen oocytes. It's helpful for frozen oocytes, not for fresh. In fresh, ultimately you have to expose more than routine ICSI to see the spindles. Second thing is we did hundreds of oocytes with poloscope. Only 3 or 4 we have seen with the above 90-degree angles. So if you do ICSI at perfect time after 38 to 40 hours post HCG, means there may be lesser chances of the spindle more than 90 degrees.
Very true. Very true. Well said.
Absolutely true, Harsha. And another thing is that it is more operator skill, because if you do the denuding with an aggressive approach, you may dislocate the porous body. So those who are skillful people and they do gently, they handle their eggs gently. So you may not find any difficulties in locating.
Great. So let's move on to the sperm now to see, what are the factors that probably are going to do so. I think let's start with Dr. Harsha. He's done so much of work on the sperm. Are there any factors from the male side which again could predispose to a failure of fertilization?
Yeah, as I said, some mutation, genetic mutation, sometimes DNA fragmentation index, lifestyle obviously affects. Post-COVID, after 2 months, we need to especially check the DFI because it increases post-COVID. We have so many patients having 70-75% DNA fragmentation index. So DFI affect maturity of sperms in testicular samples. Sometimes affect the
DFI is a point. There could be various underlying pathologies, but I think looking at the raised sperm DNA fragmentation, and if it's raised, that could be one of the risk factors, and we got to deal with it. What possibly are the other we all know physiologically centrosomes and the PLC zeta are important to initiate the whole process of fertilization. But how common are these, and how do we identify them? Dr. Rajiv, Dr. Paresh, if you're around. Issues with centrosomes and deficiency of PNC zeta. How common are these? All right, if lost them, Falguni.
We can ask Rahul if you can answer.
Rahul and Falguni, if you could just. Yeah. Is this whole hypothesis still at a research level, or do we have enough evidence to say that yes, this is how you identify an issue with centrosome and probably with PLC zeta, and what can we do with that? Where are we with this whole research concept?
I think no one is responding, so probably they are not online. So I believe still we are in infancy, and we do not have any direct assays or tests that can reveal that yes, we have some problems with the PLC zeta or centrosomes. And we all know that the oocytes that do not have the required machinery to initiate the aster formation, and you need sperm to do that. But still, we do not have those things. So those are probably the research tools than the routine.
All right.
Thing.
Can recurrent genital tract infection predispose issues with fertilization?
Yes, why not?
Again, the pathogenesis would be through the DNA fragmentation, or would there be another concern?
To me, this particular, I mean, I'm fascinated with the process of fertilization. I'm in awe of this. And according to me, we still know just a tip of iceberg.
Yeah.
There is so much to know.
So much to know.
So the fertilization, the way it happens in the in vivo environment is totally different that we see or what we do in our laboratories. So there are so many other things which may, and every day we know something or other which is coming up new.
Dr. Joshi, how far sperm morphological defects and abnormalities, anything in specific that we should be concerned while we are choosing the sperm at ICSI? That you want to warn us?
Yes, most of the time it is the morphology what we see, because I'm not used to very much of this IMSI and all other fancy gadgets, but I still give more focus on the morphology, sperm morphology, and try to apply this Kruger's criteria. Although if you apply it very strictly, you will find hardly few normal sperms. So that is the only criteria right now which I am used to. I'm not using much out of it. And
so
yes,
eye of the embryologist is still the best way to select the sperm.
I think so.
The experience and eye?
Yes, because that is the only way. You cannot have any live kind of assessment with the DNA or whether it is normal or abnormal and all. This is all our experience only. So I think, yes, DFI may be one of the additional help in that if there is
I've got an inquisitive thing, always this has kind of been behind my mind to all the seniors here, Dr. Rajiv, Dr. Shukla, and Dr. Joshi, and everyone. Physiologically, we know, capacitation, hyperactivation, the acrosome reaction, three physiological processes that have to fall in place. Otherwise, the sperm is not ready to go and fertilize the oocyte. And this was found like decades ago. Only if we could come up with some way of diagnosing this, we would probably end up doing more IVF and less ICSI. The fear of failure is pushing the entire generation, forcibly making us believe that ICSI is the only way we could force fertilization.
Correct. I fully agree. Yes, this is what we are discussing today about the failed fertilization, because that's a nightmare for, I think, still today. As I said, I have that question in my mind in the evening hours that what is going to happen tomorrow, because you never know what factor will come in picture and what is there. But yes, we can always keep on.
With that
exploring.
background, so anybody out here who could let us know, how do we plan an IVF? How do we be more careful with the sperm to ensure that our fertilizations are better? Are there any things that you could do before? Let's say the patient is very curious to get an IVF insemination done and doesn't want ICSI. So as embryologists and ART specialists, do we take some precautions with the sperm, some tests or anything? Anybody who wants to take that question?
Yes. So to me,
Yes.
I have just single parameter, which is total motile sperm concentration post-wash, and that is, the rapid progressive total motile sperm.
Right. And how much would you want that, sir?
At least 5 million post-wash rapid
So
motile.
for all the juniors hearing out there, if you have a total motile sperm concentration of something around 5 million of total motile concentration, I think, you can still consider doing an IVF. And in a non-male factor case, the outcome between IVF ICSI is not going to be any different. And that's what the ASRM's 2021 good practice guidelines also puts across. So Phalguni, I think you had something to add there. Can you come in?
No, yes, yes. When a patient want ki, I am planning for means we have to go ahead for a IVF. So what are the precautions that we have to take? It's from when we are going to give the container to the patient, just explain them how they should give and what are the precautions they should take. And once you have collected the sperm, once it is in your lab, follow your all the SOPs. The liquefaction timing or whatever the timing your sperm should be processed in your SOP timing that you have fixed for your lab. And when you are doing your centrifugation, and also each parameter is important when you are planning for IVF. And once the sperm is prepared, yes, because it is a artificial thing, so we are doing the sperm hyperactivation and all these things through the sperm preparation. Make sure a pre-analysis of the sperm is, sir has told, Dr. Sanjay sir has told the motility, how it is. If it is going like a hyperactive, then you can consider, yes, I can expect a good fertilization rate. If the sperms they are going rapid, but they are not in that way, they are not in that oscillating way, then you should think once again what to do.
Lovely. So I think sperm definitely is an important factor, and looking at the motility, because right now, though there have been some assays by scientists in the past where they have tried testing for hyperactivation, acrosome reaction, when it comes to reality in practice, their application to predict the sperm's fertilizing ability is still limited. And I think DNA fragmentation probably to an extent is useful, and I think we've thrown some light on that. So I think, Nishad, you would want to take the next slide
So,
and continue the discussion.
right. So I would like to also add one thing to that. If somebody can address the elephant in the room, is whether the pre-treatment has any role, because is it related to DFI? Whether you are actually, many a time it's just patient comes and you start with the cycle. There is no pre-treatment. So in case you can handle the situation and whether that has correlation with DFI and the fertilization, can somebody talk on that also?
If your DFI is higher, I think you have the alternate device if you are doing like your Zymote or sperm shorter or something like that. So because you don't have time, and suppose if you have a medication also, when you are picking the ICSI sperm, you are not sure that you are taking the right sperm, how is the DFI or something like that. And if the count is good, and if you're thinking the count is very less, so that you can do in the DFI. So I think it is always good you talk with a clinician, you plan for a TISA, so your DFI rate will be minimal. So that's my personal view.
All right. So what are the corrective actions? Do you think the mentioned actions do make some role? The new techniques, that is the max microfluidics, do they increase the fertilization rate? What is your take on that? Is Rahul with us right now?
Yes, Nishad.
Yeah, Rahul, please go ahead.
The use of these the latest techniques for assisting ICSI, they might not increase the chances of fertilization. It may be the same as per the conventional ICSI, but the quality of embryo, and at some instance in some group of patients, they may increase the chance of implantation. So techniques like PIXI, MAX, and microfluidics, they have the tendency to sort these sperms with good quality of DNA or intact DNA in it. So in this particular group, there is the chances of getting good quality embryo outcomes as well as implantation. But talking about IMSI, it may not directly influence the chances of maximizing ICSI outcomes. So in my point, I think PIXI, MAX, and microfluidics will work in some group of patients.
So I think, straight to the point, Rahul, to just, if you could throw some light, leave the embryo development dynamics, we're talking more about fertilization. Would any of these interventions give you that comfort that, you've picked the right sperm and tomorrow you're going to have the best fertilization?
see, picking up the sperm, because what we are doing is we are doing just a test. Like in Pixie, we are just getting a sperm that is adhered to that hyaluronan gel. And in Max, what we are doing is we are just checking the sperms which are adhered, means with the sperms with the means
Yeah, which has come
adherence
out of the
properties.
biopsy column.
Yeah. So they may
So I think the point, Rahul, because you're breaking, I'm just trying to take over there. You know, probably it's going to optimize the sperms with good DNA, but it is not the straight answer for a failed fertilization. If there's an issue with DNA, probably these, the so-called fancy gadgets, the expensive ones would probably aid in improving, but it's probably not a magical answer.
Yeah.
So I don't know if there's any one of you seniors who would help us with this. In one fail, somebody with an oligozoospermia or cryptozoospermia, you've done 1XE, you've had not a total fail, but a poor fertilization. In the next cycle, your clinician comes and says, can we do a TISA-ICSI? What is your take? Would you be wanting to do TISA-ICSI in the next cycle?
Of course.
Would that, what does the evidence say? Does it really help in getting better fertilization the subsequent cycles just because the first one did not? Just doing a testicular aspiration?
Yes.
All right, thank you, Palguni. This Dr. Harsha,
Yeah,
have you had
Krishna, I think Pixie, Max and microfluidics are the procedure which we can use in normozoospermic. In cryptozoospermic and severe oligoacinoteratospermic patients, we cannot use this procedure. So TISA-ICSI will be better for these types of patients. I think so.
So last comment on, what is the take of all my senior embryologists here on use of calcium ionophores like theophylline or pentoxifylline? Do you really recommend their use? How safe is it?
Pentoxifylline is, we all know it is already banned. So theophylline we can use in TISA sperm where zero motility is there.
So if you have a switching sperm, I don't think there's any role for theophylline then?
For selection of sperm, we need motile sperm. So theophylline, I think we can use for TISA non-motile sperms only. In ejaculate sperms, I'm not having good results. 100%.
But would it improve in fertilizing, or it's only selecting the viable sperm?
Obviously, it is help us for selecting viable sperm, so it increase the fertilization. Better to have a motile sperm than non-motile sperms.
Lovely. Thank you for that input. Nishad, did you want to add something?
Yeah, so obviously treatment of the man is the main thing, as mentioned earlier, that pre-treatment does relate and does result in a better fertilization rate and better outcome. So these are the things. And as mentioned about Pixie Max microfluidic, I believe the panel is quite on the same level right now that they do help us. But in case of normospermia, when it comes to the TISA sperm, yes. In case of oligozoospermia, especially in case of SO80, yes. TISA sperm is a better option. And I don't believe there is anybody in this panel who believes MC is the answer to it. I hope there is nobody. Lovely. So let's move on to the next question. Yeah, let's move on to the next question. So yes, about the oocyte sperm interaction. So what is the basic thing that whether low number of mature oocytes are obtained? What are the factors that result in low mature oocytes? And do these factors make a difference in fertilization? Can we start with the first one? Whether PCOS is there? Do you have fertilization failure in PCOS? And what are the factors? Rahul, can you start with this?
See, the maturity of oocytes is basically starts with the phenomena of stimulation that we all going to skip it. But after the retrieval, the assessment role plays a very important task. So assessment of COCs, it can actually highlight a few points where we can actually predict whether the oocyte is mature or immature. And after the denudation, there is a clear-cut picture whether on the maturity of oocyte. But as to see, there is the low number in the maturity of oocyte. There comes the importance of what
Do we
hello,
have?
yes,
Yeah.
am I audible?
Yeah. Please go ahead.
Yes, sorry for my this bad network is there. So
It's okay. No worries.
yeah.
Yeah. Okay. So that is one part. And my question to the whole panel: will you inject an M1 oocyte, and whether it will result in fertilization? What is your take? I'll start with Falguni this time.
I can make my practice with the M1, but it will not fertilize.
Yeah.
Because
And
if I take a
yeah.
form or something, I don't want to waste it. So I will go ahead with the flow. So that I will do.
Yeah.
See, sometimes M1 oocytes get fertilized also, but blastocyst formation rate is very, very low. So me also doing M1 injection, but rare case.
So
I think
is it
ideally
advisable
and
not to go in for a ICSI of such M1s? What is
yeah,
your take?
ideally, I think injection of M1 oocyte is not a correct way because the oocyte is chromosomally abnormal there. It's basically a, diploid oocyte, and where the polar body extrusion has not happened already there. So I basically skip this thing that injecting of M1 oocytes, because if they gets incorporate into the normal cohort of embryos, then it may affect the outcome. So I basically do not do M1 injections.
So right now we are
I'm sorry, Rahul, I differ here.
Yeah.
So M1 oocytes are not diploid oocytes, and people have attempted
Exactly.
M1
They will not
oocytes.
deploy. Yeah.
So, but the thing is, because probably this belongs or this relates to the new generation practitioners, ICSI practitioners, because in our time we had enough time to wait for the M1 to become M2 and then inject.
Yes,
So,
yes,
but
sir.
but otherwise, if you are in hurry, you can still inject M1 oocyte, but keep them in a separate droplet and observe the development and competence. And um, uh, I was for last 3-4 days with some of the stalwarts of this particular aspect, like Jack Cohen and David Mortimer, Thomas Abner, and David McCullough. And we were all discussing only fertilization for 4 days. So there are so many things. It's not like that. And David McCullough is working on one of the products so that we can have that thing to help us with the rescue of M1s and GVs. So maybe in coming days, we may be able to mature them in our labs perfectly and then inject. But then we will have to freeze all those embryos that are developed after the maturation, and then in synchrony with the endometrial receptivity, maybe in subsequent cycles we can defer embryo transfer.
Right.
Yes, I very much agree with you, Sanjay sir. But the thing is, what we are performing in the lab is we are just doing, or we are just assessing the oocyte at a point check. Means we have done the denudation and we have just checked the oocyte and it's an M1 oocyte. We are not aware what background it may have, or it may have happened there in the oocyte. So technically speaking, just like you have mentioned, if there is in hurry, but I think when in the lab and when we are on the ICSI station, there is all we need to have the patient and the calm. So I basically personally believe that it's not good or it's not viable to inject an M1 oocyte. It's the research aspect may be much more there in the literature.
So I think, let's quickly, there are quite a few clinical scenarios which can affect. So let's get more to the lab side to see, what could have been the reasons from when you're doing an IVF, why should you have a total failed fertilization? If one of you could quickly take us through what is significant, and if there is a team of embryologists wanting to do IVF, could you just help us with some tips and tricks so that we could try and minimize failed FERT or a less FERT?
Okay, so I have two suggestions. Number one, ask the male patient, the partner, to have frequent ejaculation before you collect the sample. And it is advisable to have maybe 2 subsequent samples on the same day of your IVF, and use the later one before you go for ICSI, or if you think that this is not good for regular insemination IVF. So that is one thing. Another thing is process the sample as soon as possible. Do not keep the sample lying on the table.
Yeah.
So these are 2 simple practical tips.
Lovely, lovely. So would you want the sample to be left in the gassed incubator for 30 minutes for a swim up post process and then inseminate? Would that kind of give you a better outcome?
Maybe, but again, a word of caution, because if you are putting the things, post preparations in the CO2 incubators with 37 degrees centigrade, you are increasing the metabolism rate, and they will get exhausted faster.
So any other panelists who would want to add or give us some inputs to optimize IVF fertilization? Lovely.
I'm agree with Sanjay sir that consecutive collection, plus I'm not using CO2 incubator. It increase the capacitation and exhaust the sperm. So I'm totally agree with Sanjay sir.
Lovely. So if I'm allowed to add, there are a couple of things that, I was taught way back at Monash. If you've done IVF insemination, the next day morning, it's just not about seeing the PN. What they also would stress and let us see is, how good was the cumulus dispersion and separation. That would indirectly tell us if the sperm had done its physiology. You have a good 2PN, all of that is okay, but still there was a routine practice where they would make us write in the worksheet, how was the cumulus dispersion? Yeah. Did they see any sperm bound onto the zona? And they would also want us to look at the percentage of motile cells that we would see at FERT check. They say this would talk more about the sperm's physiology and capacity. And if at all there was a lesser FERT or total FERT, if there was no cumulus dispersion, very poor motility, or no sperm onto zona, then they would say this is more of a male factor, sperm related factor, and they would subsequent cycles go for ICSI. So this is what I was taught, and I thought it would be nice to share it with you all.
Yeah,
so
I completely agree with you, Krishna sir. But one thing I would like to stress here again is, in our laboratory conditions, we follow a short incubation protocol also. Means to short in 3 to 4 hours of incubation of COCs and sperms together, and after that to separate them in a fresh culture media dish and to check PN later on the next day. So it may somewhere can also improve the fertilization and embryo outcomes as well.
Absolutely. The ROS is lesser from the sperm that's generating it. And second, I think it makes it so easy, because you've kind of reduced the cumulus density, and next day you do not have that tenting effect. If somebody has ever experienced this, so dense cumulus, if you've left everything for 16 hours, sometimes they seed to your plate and you're wanting to pick a oocyte and you have a whole mass of cumulus that comes, and it makes it very stressful. Beginning days, my heart used to sing that I've lost my embryos, and then I had to use hyaluronidase sometimes to denute. So a shorter insemination protocol really helps. It makes it a lot more easier to do the FERT check the next day.
Can you elaborate on the shorter insemination protocol, Krishna? Like, let's everybody know about it.
So, in IVF insemination, we're putting the cumulus and the sperms together. You've done your calculation. Now, with so much of ROS and DFI concept coming and so much of light thrown there, and sperm is a cell which generates a lot of ROS. So you're leaving millions of sperm cells in a very nice environment, conducive environment, so the ROS generation can go up. So they say doing a long protocol, that is, leaving it for 16 to 18 hours and then doing a FERT check sometimes could be a little detrimental thing. So then they came with a short insemination protocol where they would put the egg and sperm together at, say, 12 o'clock in the afternoon. By 3 or 4 o'clock, they'd quickly see if the sperm was hyperactivated and the cumulus dispersion had started. Then they pick only the oocytes, and they don't denude or anything. They pick it and they put it in a fresh dish. By this, I think if the sperm had already gone into the zona, it would have done in this first 3 to 4 hours. Leaving it for 16 hours will not improve your fertilization. And the ROS effect also comes down, so your embryo quality improves. Whether it is short or long, the fertilization rates did not change. So I think whoever's doing IVF, most of them have changed to short insemination protocol.
Yeah, I believe this is the James Cath method.
Yes.
Right. So just in addition to that, short protocol, even I have tried that. I used to shift after 4 hours because technically in insemination, 3.5 hours is enough for the sperm to penetrate inside the cumulus and enter the zona and enter the oocyte. Now the catch is you can shift it, but you need that much amount of time. The embryologist and everything has to be planned. And like what Krishna said, yes, it doesn't make much of a difference, but yes, if you can manage the ratio of sperms to your the droplet size. For example, technically you require 1 ml if you have around 7 to 8 oocytes or COCs. Okay, and if you put in around 1 lakh to 2 lakh sperm, they will do the job. So having a bigger size drop, having only X number of sperm, which is a threshold which will help in fertilization, is a good number to attain fertilization with IVF. ICSI, yes, everybody does it. The catch is how to get back to IVF now. So if you have this ratio, probably, then you will not have fertilization failure and the ROS will not affect the fertilization in the future.
So let's go to the next slide. So
yeah,
Nishal, you could take over the next slide.
Right. So fertilization failure in ICSI, what are the reasons for it? How do the factors affect? Harshaven, can you take this one?
First of all, technique of ICSI is we already discussed the cone shape formation.
Yeah.
Second thing is selection of sperms. If you have a OAT or cryptozoosperm, you need to change the sperm processing and all. These are sometimes oocytes also affect the fertilization. So you need to see all the abnormality in the oocytes. That's it, I think so.
Okay. Anybody thinks that the time of ICSI is also important? Does it make a difference to the fertilization rate?
Yes, obviously it is very, very important. Time of ICSI for cytoplasm maturation. Also, you need 38 to 40 hours post HCG injection.
So have you noticed any difference that if you're doing ICSI post 40 hours, maybe around 41 or 42 hours, does it affect the fertilization or does it only affect the ICSI? What is your experience has been regarding the elasticity of the oocyte post 40 hours?
My protocol is around 38 to 40 hours post. Okay. I haven't any. I am getting good fertilization.
All right. Is there anybody on the panel who's done or has any idea about post 40 hours? What is the scenario and of the oocyte, and does it affect your fertilization?
Yes, yes, Nishad.
Yeah.
I think after a period of time, like after 42 hours of HCG, as Falguni has already mentioned that there is the formation of cone during the ICSI. It may not be easily seen there in that situation. Means the quality of oocyte will not be as intact what we see before or on 40th hour of HCG at the time of injection. So I think the quality of oocyte somewhere disrupts the process of ICSI as you prolong the time of injection.
Okay. So I'll add to this that basically the elasticity after 40 hours increases to that extent that when you are actually injecting the oocyte with the sperm, when you're injecting the sperm, you can crisscross and go across the zona from one end to another, and that will destroy the quality or the vitality of the oocyte. That seems to be more of a problem regarding the elasticity, which results in fertilization failure. So the take-home message is that avoid doing ICSIs after 40 hours. Try to finish off within your 40 hours margin so that such oocytes do not happen. And anybody would like to comment on the exposure time while you're doing ICSI? What time do you keep the oocytes outside on the micromanipulator? How much is the time you keep outside the incubator? Any ideas or any views on that?
Is
Sanjay sir?
minimal as
Yeah,
possible.
Yeah, any time frame would you like to mention that you calculate?
Here two points I would like to add. Ki suppose is for your previous question ki if you are exceeding 40 hour or something, that don't post denudation, don't wait for more, or if you are thinking ki suppose it is a TISA sample to get some sperm, it might take for another 3 to 4 hours, you are crossing 40 hour, then do not denude the egg and keep it for longer period. Keep your egg with your cumulus. Once you are okay, now within 30 minutes I can start my ICSI. Around that time you denude the egg. That will help. But if you are denuding the egg for a longer timing and you are doing ICSI after 3 to 4 hours, then you will get this issue of your elasticity.
Okay.
And if you are doing your ICSI and all, I think once your sperm selection is done, I think 1 to 2 minutes is fine. Maximum.
Okay. Charu sir, would you like to add anything to that?
Yes, definitely. And my experience, what I have seen is it is all matter of time that you just keep on doing, and then time it comes when you can do it as early as possible. As far as answer to your question is concerned, this should be as minimum as possible. That is what we can say. But on an average, if you see, almost it takes around 15 to 30 seconds, 15 seconds to 20 seconds for injecting one oocyte if everything is in proper shape and proper functioning. So my point is that ICSI time exposure will depend on so many other factors also, like the machine maintenance also. It's very important. So what I can suggest here is, initially, which I'm also doing even in some cases right now, that first have the sperm selected, keep them ready, then as per your convenience, take 2 oocytes or 3 oocytes at a time to avoid the exposure. I have seen in Belgium, when I visited them, they used to take 15-20 sperms together and inject one by one. I cannot imagine that at that time. But that is possible with the time. If you have that much of exposure and that much of experience, you can do it. But this is the ideal way of doing to reduce the exposure. Exposure should be reduced as much as possible.
Right, rightly said. All right. So these are the factors. The rest we have already discussed, when the oocyte and the ROS and the improper sperm preparation techniques, obviously, and the cytoplasmic asynchrony. I believe we have discussed all that. Krishna, will take the next question now.
Yeah. Well, I think we would, are there any preventive strategies? We spoke about, of course, we can't change the patient. We spoke about the calcium ionophores. And the timing and everything. One straight question to all my seniors and panelists there. If there is a failed fertilization or a very poor fertilization, when is it that you want to discuss about a third-party reproduction with the couple? Do you want to do it immediately in the next cycle, or do you want to still convince the patient to do another cycle where you're going to do some corrective actions like a calcium ionophore, sperm selection, and something in the lab? Or do you think, third party is their next option? Can you help us some inputs with that?
Are we at the luxury of doing third-party reproduction now?
A little scientific, Sanjay sir, because there's so many times where people just look at poor FERT and they're forced to say that no, go for third party, but leaving the law and other thing, should we be really doing it, or there can be a better outcome the next cycle? Let's give it a shot. I'm sure it's a lot of money to the patient, but self-gamete conception is still something that a patient deserves.
True.
I would
So,
like to go for a second cycle with the same thing, not for a third party. If in the second cycle is the same issue, then I might be think for the next one.
All
I
right.
think it is, if it is total fertilization failure, then we need to source the reasons. Like if it is genetic reason or any oocyte activation failure reason, we need to see those zona binding assays also before going to third party.
Pixie, you believe?
There is one test, sperm zona binding assays. You can keep the sperms with zona. I think Charu sir must know that. And then you can see how many sperms are going into the zona after washing it, say a half an hour. And then you can see whether sperms are going inside the zona or not. It is assay called sperm zona binding.
Yeah. That is practical. Is it practical in today's world? I mean, that is another question. So, would like to know any practical uses of it, because it's very difficult.
No, that you rightly said, Nishad. I don't think that zona assay binding and all these things is practically possible nowadays. But see, the question answer to this question is that first we have to be very much ensured about what may be the possible reason of failed fertilization. We have to find out a reason, as rightly said by Dr. Harsha. If not, then at least patient has to be counseled in depth properly with all possible options available. And then if patient wants to go ahead, that thought also has to be given for the second cycle, because just doing a second cycle and then again landing with the same problem, then patient is ultimately going to ask you because we are responsible for answering them. So I think proper counseling and proper option explaining to patient will help, and then we can decide. Like even if we say oocyte activation and all, we all know this media and everything is not readily available, and we don't know well in hand. So if it has to be planned, it has to be planned for next cycle well in time, so that we should have all disposable media, everything required for that particular procedure for that particular patient. So it needs a proper planning also. So these are the two things which I suggest.
All right. One thing, again, we don't know how practical this is. I would want all our expert panelists to comment. If the patient agrees, and if there are more number of oocytes, should we be doing like 60, 40, 70, 30 of, some with donor sperm? Let's say that I've got 18 oocytes, 10 with husband sperm, 8 with donor sperm, keep everything separate. And again, in the next cycle, if in that cycle, if the husband sperm and self egg did not have any fertilization, but donor gives, at least there's an answer that, it was more of the sperm causing all of this. And I think, doing another cycle is not required if the patient is okay to get those donor created embryos as for transfer. Would this be a little balanced approach in an Indian scenario where patient is paying out of pocket?
Previously, yes, it was, but nowadays I don't think this is a right option to give to the patient or even do that, because if you form the embryos, where to keep and what to do and all these things, you need a proper consent from patient. So many things are involved now. So I don't think it's a practical idea now.
The third party should
Yes.
be the immediate action. I think there are quite a few things that have come into.
We have a solid reason for that. Now we have to explain that this is the possible this thing. Inside you do whatever R&D you want to do, but officially you cannot do. That is what I think.
Ganesha, let's go to the next.
Right. Okay, so I think this is the most important part for all of us. The laboratory aspect. What are the factors that can lead to fertilization failure due to lab problems or lab conditions? Sanjay sir, can you start with this one?
Yes, so from the very day of my research, when I started entering my laboratory, my boss told me that the troubleshooting starts with the word me. So whenever you think that something is problematic, think of yourself first, that whether you are doing the things right or not. And very simple to understand that the moment we feel that, yes, we are doing very well, we are confident, and now our lab is working wonderfully with a certain standard, we become complacent and we make errors. So embryologist skills is of paramount importance, and that needs to be reviewed and updated time to time.
Right. Harsha Ben, Falguni would like to add to the lab parameters that would affect the fertilization failure.
If you are getting constant fertilization failure or low fertilization rate, then these are the aspects which should be reviewed, embryologist skill and lab QA/QC. But in rare case, if you are getting, then you should go for patient's parameter also.
Right. Okay. Falguni, would like to add to this? And Rahul, please.
If you have your FOD failure, then you have to see for both the thing, for a sperm and your egg. If you are thinking you have to taking a precaution, but if a FOD failure means it's a question mark to means first the question will go to the lab. I think some problem with the lab, maybe you have to take a swab culture condition that the microbial, how's the growth and those things, so that you have to cross check. And when the sperm has came to the lab, when it has prepared, how much time it took, whether it's prepared properly or not, so that also you have to take care. And you have to see because in one center what has happened means sometimes it might be a troubleshooting, it may be helpful to other. It was a new lab, and some of my friend has went for a to do the batch, and after the pickup he has did his cases. He came out, but who was the night man, I think he thought when the light will be on, so he has switch off all things. And on the next day when they have went, so that might be, so when you are thinking in it's a new lab or something, take a double check, take a double precaution, you have to inform properly to your junior and all, you have to do in this way. So I think all these things we have to take into a consideration for a sperm and for your for your egg. Yes, you have to take how is the egg quality and all. So you have to keep your notes. So from these things from the lab side will help.
Yeah.
So I believe.
Can I add something here?
Yes, sir. Please go ahead.
See, for me, I think the answer to all this thing is SOPs. You need to follow them, and I think this is in my practical experience. I have seen that, like for example, Contracon and lab cleaning. Now, this is two things which some people think that it has to be done on daily basis. Sometimes, if they are doing in batches, they think that everything has to be done from the beginning. Before preparing the cases, you need to clean lab again and everything, and so many things. And then all of a sudden they came to know that there is some problem and there is low fertilization and all. So I think the best way of looking into it is that, as Shuklaji rightly said, first you see whether there is any technical error, laboratory person's error. And if it is not there, then we should stick to a particular protocol. And again, to my experience, I would like to say, even if in one or two cases you see a failure, immediately do not reach to any conclusion that, oh, there may be this problem or that problem. you have to give a stepwise thought to it. Where should be the problem? It may be patient factor or it may be lab factor. You cannot say, or it may be some mistake by some of the staff member also. That is also possible. But then I think if you have system in place, this type of problem can be very well taken.
Yeah. Right. So, yeah. Yes, sir, please.
So here comes in picture the concept of TQM.
Absolutely, very true. Wonderful.
I'm sure Krishna would agree to me, because he is a laboratory director of so many laboratories working, so many embryologists under him, that if you have a robust TQM in place, I can vouch for it that almost 99.99% of all these laboratory aspects can be taken care, and you are damn sure that all these aspects or related laboratory aspects are working fine. So your troubleshooting and root cause analysis time reduces, and then you have the brainstorming regarding other aspects. So if you have a robust TQM in place, you can be pretty sure that these things are working well.
Right. Very rightly said, sir. So these are the factors I believe that obviously, as mentioned by all our panelists, that the skills, there are equipments, total quality management, security system, power supply, instrument calibration, QA, QC, all are related, whether they have to be managed, whether you're managing one lab, whether you're managing 5 or 10 labs. So if you have got the SOP set and all these processes set, the problem will be solved. So I believe we'll move on to the next question, Krishna.
I think, yes, we spoke about TQMS and everything. I think media, another important aspect. Can this be a sole contributor for a failed fertilization?
Yeah, I think everybody blames the culture media in the first place. The rest is all gone.
It's never the first person to be blamed is the embryologist, and then the embryologist says it's the media. So, what's your take on this?
Definitely.
Can we start with you?
Yeah, definitely the cold chain maintenance and equilibration timings are also important for the culture medium. pH, as I said, equilibration time increases, pH decreases. Exposure of culture medium, when you're preparing dish, you need to see the exposure of culture medium. Expiry date, obviously we have to see on the pack at the time of dish preparation or whenever we get the media. So these are the most important aspect of culture medium.
Wonderful. I think it all narrows down to having a proper TQM in place, a total quality management, where you're looking at every aspect again and again. I keep telling all my team, it is a donkey's job. No offense, but it is a donkey's. You got to do the same thing again and again. Just because you had wonderful pregnancies and blastocysts last week doesn't mean you're going to relax back this week. You've got to equally work harder this week as well. And that is when the results are going to maintain. Getting to that point probably sometimes is done, but maintaining it and going beyond that is where the whole struggle is. And I think thanks to the science and technology, fortunately, we are not in the era where Dr. Sanjay and Dr. Charu were there, where I think it was more of hit and run. Things would go wrong. It would be frustrating. There wasn't much of Google at that point where they could go and search for answers. But I think so many webinars happening, so much of information, blogs written. For a lot of embryologists like me, I think the current era has not been that difficult and challenging. But, it's common sense, it's presence of mind, and the whole perseverance to keep doing the same quality control again and again is what is going to help you get the best. So let's go to the next slide.
I believe that's what. But I'd like to ask one more question regarding the equilibration. There have been lots of debate, discussions, right or wrong. How much time should you put the media for equilibration? I have heard people saying that 3 and 4 hours is also fine and 2 hours is also fine, but we should keep it 18 hours. But sometimes people say it's more than 24 hours, then you have a problem. So what is the right equilibration time? What is the proper incubation time for the media?
Instructed by the company, follow it.
Now, I would say it all depends on the way you prepare your dishes.
Very true. Wonderfully said.
So the amount of oil, whether you are doing open, medium, or the under oil dishes preparation, the size of your droplets. So all these things matter. So it all depends on how you are preparing the dishes. So stick to your protocol. But as you said, if it is like even 3 to 4 hours, you can still work. But it is only in case of emergencies, not as a routine protocol.
Agreed. But do you think 3 to 4 hours is still a very dicey situation? At least 5 hours, 6 hours should be your threshold sometimes in case of emergencies also?
It is, but still, if I can quote it, it's off the record, but in fact, Chowdhury Joshi was also there in one of Alpha conference in Copenhagen, and we discussed this at length. And if you go through the Patrick Quinn's this booklet, it's wonderfully written, and we believe it's a Bible for all of us. So it also recommends that at least 2 hours of incubation is needed, if not proper overnight.
And the quantity, volume also matters in this case. It has to be very less. Only then, if the surface area to volume ratio changes, then everything changes.
Yeah, you need to understand the physics also along the chemistry.
Yeah. Right, sir. So let us move on to the take-home message. We've had a wonderful panel, and I believe that what is more important here is that one should understand that quality control is very important. We have to take care of our certification and training, how good our embryologists or our team members are. This is very important, that they have to be properly trained. They should have proper documentation in today's time, including that your total quality management is the main thing in the lab that is most important, that will help you to avoid scenarios like fertilization failure when it comes to the lab aspect of it. Obviously, equipment maintenance, AMCs, these are the other things that you have to consider. We just talked about culture media, what we have to take care, what is the incubation time, what are the rest of the factors related to that, whether we should be able to check the osmolality, the pH. These are also very important factors. And most importantly is the patient selection, that whether the patient age is proper, the AMH is right, what is the physiology or the diagnosis of the patient, whether that will affect the oocyte and the sperm quality. So these are the factors that also affect your fertilization failure. Always important is the monitoring of the procedures, whether they have been done properly, whether they have been documented properly. This is very important, because if you don't take pictures, if you don't log the data, how are you going to retrospectively determine what has gone wrong? And very important is the patient communication. If you are having proper counseling, proper patient communication, then you'll be able to determine what is happening. So by implementing all these factors, we can actually avoid situations like fertilization failure. And I believe we've had a wonderful panel with such great panelists and wonderful discussion on intricate matters of fertilization failure. Krishna would like to say something regarding.
I think Krishna is left because he has to, that there is fast, that's why he's gone for puja. So Krishna is not there.
Okay. So I believe we are done with it anyways. So that was the last slide. So we actually finished the panel and all the questions. I'm very thankful to Ved sir, Sanjay sir, and Charjat sir for the opportunity, and all my panelists, Harsha Ben, Rahul, Falguni, Rajiv sir, everybody there, that you have contributed a lot and making a very good discussion and kind of a debatable topic on certain topics. So thank you very much for a wonderful panel here, and I hope you have a wonderful evening.
Thank you, Nishad. And
working, I don't know.
Okay, Wetzer, before you share your screen, can I share one slide?
Yeah, please. I'm stopping. I think it is stopped already. Check. Yes, please.
So here I want to show you one picture. Just give me a second. I'm sorry to keep you waiting.
No, it's okay.
So is it visible?
Yes.
So have a look on this particular slide. This was recently presented at UES conference. And look what the person responsible for maintaining this record did. So according to this picture, what they did, they were keeping the record track of temperature in the warmer, and the person responsible for recording changed the limit. If you see, it was written 36.0 to 37.5, and she changed it to 35 to 40.
Oh.
And then here, again, someone found that, yes, the readings are not in the range. So it was again changed to 34 to 40 degrees. Now, if you fiddle with this thing, which was for your quality management thing and quality assurance thing, if you fiddle with those things, you are not going to get the proper results and you are in a soup.
No, actually, we have to take care of all these small things also every time. Even you are changing any disposable kind of things and what is coming in your lab, we have to take care of everything.
So I believe the take-home message is you need one embryologist just to monitor and write everything other than the person performing.
Yes. At least junior embryologists can do these things. At least no junior to at least trainee embryologists can do this. Correct. So before we end, I want to share again that workshop IHERA is going to do in April 14 to 16. Venue is Lovely Professional University. And now there is one more announcement that there is a special offer for students. Only for 10 students. They can join this training for 32,000. And for others it is 42,000. It is 3 days training, and 16 experts will be there to train you in each and every aspects of ICSI, and there will be engineers also who are going to tell you about the machine, how it works, and what is the different kind of machines are available in India and abroad. So there will be a robo ICSI also, and we are planning to arrange one more ICSI from Israel, where you can see real time. You can check real time DNA fragmentation, and you can pick that sperm. So these are the highlights, and thank you so much for joining us. Dr. Shukla, you want to say something for at the end? Always Dr. Shukla is there to for vote of thanks.
So thank you very much, all the participants, panelists, speakers, our wonderful duo of moderators who always have this skill to dig out the best out of all. And most important, all the attendees who are still with us for such a long period of time, and our support team from the pharma. So they all have helped us bringing you this wonderful webinar. Thank you very much and have a great weekend.
Thank you, everyone.
So,
Thank you so much.
thank you very much.
Thank you,
Thank you.
sir. Thank you all.
Thank you.
Happy
Thank you.
Shivratri to all.
Happy
Yeah,
Shivratri.
happy Mahashivratri to all.
We can stop the live recording now. Thank you so much and good night.